Welcome to the webinar. We will begin momentarily.
Okay, wow. Oh, we'll have to take that into consideration.
If everyone can just put themselves on mute, we'll get started if you don't mind. Hi, I'm Dr. Scott Greenberg from Greenberg Regenerative Medicine in Bryn Mawr, Pennsylvania, and we're going to have a brief introduction from my office manager, Sharon Hannum, and then we will get started. I think this is going to be a really exciting webinar where you're going to learn a lot of things about orthopedic pain conditions and how regenerative medicine can help and what we're all about.
I'm excited to introduce to you Dr. Scott Greenberg, who is a world-renowned integrative and regenerative medicine physician. He's a member of Bryn Mawr Hospital, an affiliate of the Mainline Health D. Adams Center for Integrative and Regenerative Medicine. Additionally, he's a clinical professor at the Marcus Institute for Integrative Medicine at the Thomas Jefferson University Hospital. Dr. Greenberg has treated patients, including pro and Olympic athletes from all over the globe who are suffering from sports medicine issues, regenerative orthopedic problems, chronic pain, arthritis, and post-concussion syndrome. He uses state-of-the-art therapies such as prolotherapy, PRP or platelet-rich plasma therapy, and he's a pioneering leader in developing and using stem cell-based procedures. His restorative programs are holistic, non-toxic, and opioid-free. Dr. Greenberg identifies and fixes the root cause of his patients' problems and helps them harness the power of their body to heal themselves. I will now turn it over to Dr. Greenberg to begin the webinar. I'm excited.
So thanks for joining. And every medical lecture I've ever been to always starts with a joke. And this joke, I think, is really great, but also really goes into what I think is a really important thing, which is to find the root cause of the problem. And if you read the caption, it says, the pain starts in my husband's lower back, then it travels up his spine to his neck, and then it comes out his mouth and into my ears, and that's why I get these headaches. So I think that's really cute. And again, we want to treat the root cause of the problem and not just treat the symptoms. So here's a patient of mine, and her name is Linda, and she's a nurse, and she had some really serious problems. And I just would like you to listen to her and just hear her story, because I think it's really interesting of what her problems were and how we helped her. And unfortunately, her problems really had no answer in traditional medicine. So she came to us for help. And if you listen to this, I think it's really a nice story.
I was unable for years to turn my head when I was looking behind me. I always had to look at the rearview mirror, and I just couldn't do it without really bad pain. I would constantly in my neck have problems with like clicking and just pain. I couldn't sit in a theater and look to the left without putting myself in the But after the stem cells and the PRP, the feeling in my feet, it's like this months later now, I feel the left is like almost completely normal, and the right is like back to cotton. It doesn't even feel, or maybe like that you had a Band-Aid, but it doesn't really have the. It's not negative, and I can walk. I have no problem. I was walking before too, but it not without awareness of that feeling, and that's improved greatly from the beginning on till now, and presumably it's going to get even better. We'll see.
So interestingly enough, Linda had some issues to where she had cervical stenosis or damage in the cervical spine and also lumbar stenosis. And this type of damage actually strangulated her nerves to where she had weakness in her hands and couldn't grasp and was dropping objects, and also this sensation she described in her feet, which basically felt numb and tingly, and it was difficult for her to walk because you need the information from your feet to go up to your brain, and she wasn't getting that because of the damage in her spine. So with using stem cells, both in the cervical spine, which is in the neck, and the lumbar spine, which is in the lower back, we were able to get her grasp up to be completely normal, and also to get her feet to start feeling again, in addition to getting the pain out of her neck and out of her back. So again, as I mentioned, this is something that really can't be done in traditional medicine. You know, we think in traditional medicine, and once the nerves are done, that they're done, and there's really no hope. And fortunately, for many of our patients, we've been able to regenerate the damage and help these patients heal and get their function back, which is really, truly amazing. So how did I get started with this? Because I've been doing this for 22 years or so. And it's interesting because back then, if you would have mentioned something like prolotherapy or PRP or stem cell treatments that many years ago, people would think it was some type of black magic. And it really isn't black magic, and it's based in great science. So I was first introduced to this by the person who you see here, C. Everett Koop, who I took care of his back. But before I took care of his back, Dr. Koop had a treatment of prolotherapy in the 1960s. And this treatment helped his back when nothing else would. And the reason why it became very important to me is because when I was a child, I was always wanting to be a retinal surgeon. That's all I wanted to do, was to be a retinal surgeon, because my grandmother had macular degeneration, which is a disease of the eye that contributes to blindness. And that was my goal, to be a doctor, to help cure blindness. That's all I wanted to do. But unfortunately, when I was 18 years old, I was hit by a drunk driver at about 75 miles an hour, and all my plans had changed. And I didn't know at the time that they had changed, but I began to suffer from what we now would call post-concussion syndrome, where I had problems with headaches and difficulty with focus and concentration, and couldn't track objects and things like that. Now, granted, I still was able to get through college and fortunately do very well and go to medical school and complete medical school and residency. But in my medical school, when I started to do ophthalmology, which would be on the path to be a retinal surgeon, I tried to look through the ophthalmoscope, which is the device used to look into people's eyes. And I couldn't see anything. And I asked the ophthalmologist I was working with, like, what's wrong? How come I can't see? All I want to do is be a retinal surgeon. And he just simply said to me, I don't know. We don't see, I don't know what's wrong with you, and you're not going to be a retinal surgeon. So the ironic thing is, nowadays I take care of his joints and he takes care of my eyes. But so I wasn't a retinal surgeon. So be that as it may, it's years later, I'm 28 years old. I've been suffering for 10 years with these chronic headaches. And I find out about the infantile, at that time, it really was not well known in regenerative medicine. And I find out that there might be ways to heal tissue. So I went to learn from the guys who originally treated Dr. Koop in the 1960s. And it was 3:30 in the morning. I'm writhing in pain. I have horrible headaches. My wife thinks I'm dying of brain cancer. Fortunately, I knew that I wasn't. And I began to examine myself. And all the pain that I felt here, which was excruciating, it felt like someone was drilling through my skull, I figured out was actually coming from here. So again, after suffering for 10 years, you'll pretty much do anything and everything to get rid of your pain. And I had been through it all. I'd been through physical therapy. I'd seen surgeons. I even had sinus surgery to see if that would help. I had seen neurologists, I had MRIs, and nothing had helped me. So at 3:30 in the morning, while I was in complete agony, I basically started to concoct some mixtures and very carefully injected my cervical spine in the base of my skull. And I went home, went to sleep, woke up in the morning, and I actually felt a little bit better. And I remember going for a walk that morning and saying, you know what, I think this actually seems to have helped, but I don't want to be subject to any placebo response. So let me just kind of ignore that it helped and let's see what happens. And then over time, the pain got a little bit better, then we get a little bit worse, got a little better. I'd give myself another treatment and so forth over the next 4 months. And after the end of that 4 months, I didn't treat myself again because the pain was gone and my 10 years of agony had gone away. And I knew that I was on the right career path. And there are many, many people out there who suffered like I did with chronic pain, and there had to be a solution to what our problems were, that it wasn't in our head, that it wasn't something made up. And this is how I've dedicated my life, to help people who have suffered like I've suffered. So it takes a team. We don't do it all by ourselves. And I have a great team here of nurses and practitioners who help us with anything from processing to helping patients understand the process, to leading them all along the way. And we have a really terrific team, and I thank them greatly for believing in what I do. And fortunately, we're able to make miracles happen almost every day. And I think it makes it a great place to work. So everyone in our office has a lot of conviction with the things that we do for our patients. So there are many different treatment options for pain. And as I mentioned, I had been through many of them. And you see that there's the conventional medicines, which are using anti-inflammatories like Motrin or Advil, or the prescription anti-inflammatories, to using muscle relaxers and having physical therapy. And then there's the surgical options. And unfortunately, I've seen many patients that have had back surgeries that are still not doing very well. If we look at under the surgery column also, there's something that's actually really very important for me to speak about, which is the meniscus debridement or meniscal surgery. And I'm sure that everyone here knows someone who had their knee scoped. Well, scoping of the knee is one of the largest surgeries that are done worldwide. And unfortunately, there were studies that were done that showed that if you took a person with arthritis and you did a scope and cleaned out their knee versus doing a fake surgery, what we found out were the people who had the real surgery actually did much worse than people that had the fake surgery. And they needed knee replacement much sooner than those that had the fake surgery. So unfortunately, we think first do no harm, but now with surgeries like this, we know that we are doing harm. And it leads to worse outcomes. And we need to think a different way in order to have our patients have a different experience and have better outcomes. And the same can also be said with rotator cuff repair, where the retear rate of fixing someone's shoulder through a surgery can be quite great, sometimes up to 90%. And studies that were done on regenerative medicine with stem cells showed that the retear rate was no more than 10%. So again, I see this as a big success. And looking at alternative therapies for pain, a lot of our patients have tried acupuncture and chiropractic and massage and different supplements. And this may be very helpful for some people, and for some people it may not be helpful. But again, it's another avenue to try that's generally non-toxic and generally relatively safe. And now tonight we're going to talk more about the regenerative therapies, which is what I specialize in, which would be prolotherapy, platelet-rich therapy, and stem cell procedures. So I'm not going to go too deep into this, but I'll give you a little bit of background and a little bit of history. So prolotherapy, even though this seems like a word that maybe you've never heard before, actually dates back to the time of Hippocrates. And Hippocrates was the team doctor to the Olympics. And the javelin throwers would dislocate their shoulders, and Hippocrates would treat them and use some type of injection into their shoulder in order to strengthen it so it wouldn't dislocate. And this is quite successful. While prolotherapy works on an indirect mechanism to cause healing, we've evolved a lot into using PRP, or platelet-rich plasma. Now, you may have heard about it because many athletes nowadays will get PRP, and I've personally administered PRP to many athletes as well. And PRP is essentially modeling how the body heals. It's really very ideal because we take the patient's blood out, we take the growth factors out of the patient's blood that cause healing, and then I very carefully place it back into the areas of damage and force those areas to heal when the body hasn't. And this is a really ideal situation because instead of trying to pick out something that we can make into a drug or something pharmaceutical or some type of growth factor, we're literally harnessing the exact concerted way that the body heals damaged tissue and putting it in where it needs to be. Now, obviously, that's the art of what we do, is you really do need to understand where to put the PRP or stem cells or what have you back into the damaged regions in order to heal something properly, because it's not like, it's not a response like an atom bomb where you just put it in and everything in the area helps, or you give it IV and it goes throughout the body. It needs to be extremely targeted by someone that really understands what the problem is, and this is how we solve the problem. So there are newer things that have been used since the 2000s, such as using stem cells, and we prefer using stem cells derived from fat. Stem cells derived from fat are really very ideal because the fat is where stem cells are stored. If you look at the slide on the left, it says bone marrow derived stem cells. This is where the stem cells are made, but the stem cells get stored in the fat. So it's kind of like, would you want to go to the manufacturing facility or to the warehouse in order to get the greatest quantity of product? So we go to the warehouse. And fat also is a really interesting thing because no one really minds getting rid of some of the fat on their body, and they're always willing to donate. And fat not only contains stem cells, but also contains several other cells here. And if you look at the words in this last paragraph that say pericytes and preadipocytes and other growth factors that are osteogenic, chondrogenic, and neurotrophic, what that means is they help to grow cartilage and bone and nerve. So this is really very ideal for using a material such as adipose in regenerative orthopedics. And this is how we help people that have cartilage issues and osteoarthritis issues and nerve damage issues. So there are some other biologics that we use, such as amniotic membrane products that basically help boost up the amount of growth factors in what we use. I think they're very helpful. There are some other products on the market, such as Wharton's jelly and chorionic products that we really won't get into at this time, but they do contain some stem cells. There are some regulatory issues with using them now, and I don't really use them right now because of those regulatory issues, but they are available, and maybe they'll be more widely used in the future. Interestingly enough, there was just a Wall Street Journal article out that many of you may have read that talked about biotechnology companies and MIT trying to develop more growth factors for use for arthritis and regenerative medicine. So I think it's really nice how we've kind of come full circle to where these products and these procedures and the thought behind this is being much more widely accepted and researched. So I'm not going to bore you too much with the biology of all these different growth factors here. And the next slide has other growth factors as well. But I'm just going to sum this up that, again, we're really trying to mimic what the body does. And, we're trying to decrease inflammation. We're trying to help the circulation. We're trying to stimulate collagen production in different areas. We're trying to stimulate the cartilage to grow. We're increasing hyaluronin, which helps with the fluidity of the knee. And many patients have had what they call the gel shots, which is hyaluronic acid. Well, we can try to help the body produce hyaluronic acid naturally by using the right types of growth factors. Instead of taking Advil, we can have the body naturally reduce the harmful parts of inflammation in the body. We can help to stimulate repair and stimulate cells to rebuild cartilage and rebuild nerves using the right growth factors. So this is basically how it works, is by working with the body rather than against the body. So I'm a holistic doctor, and I really like to look at everything from head to toe. And I think that, if we go back to the the lessons that we learned when we were kids about anatomy, it was the hip bones connected to the thigh bone and the thigh bones connected to the knee bone. And this is a little bit of how I think. And I think it's really important to watch everyone in the way they walk and to evaluate the entire body and the entire structure. Because if you look at the slide to the left where the person has a tilt in their pelvis, look at the kind of pressure this puts upon their back. Look at kind of the pressure it puts upon their hip and their knee. And if we try to treat a joint individually without treating the body, then I think we're just going to end up with mediocre results. This is why I'm so much more attuned into treating the body and looking holistically at what's going on from an orthopedic issue rather than just looking at things as a part. So let's talk about how this happens a little bit. So if we look at an X-ray, we're kind of not seeing a lot of the things that I examine physically. And you might see bones, and you might see arthritis, and you might see some other damage here, but we have a very important stabilizer of the knee called the MCL, or medial collateral ligament, and it's on the inside of the knee. And this helps people do simple things like walk up and down the stairs. And if this ligament has damage in it, which often is not shown on MRI, I can say that maybe in 100 patients that I see, maybe 1/10 of the patients, 1/10 of 100 patients have ever had damage that showed up on their MCL. But we see it all the time with every patient that comes in with knee problems has an MCL problem. And if we overlook this and don't examine the patient properly, we're going to miss it. And then the patient's going to still have difficulty going up and down the stairs. So we really need to take a very comprehensive look. And I use a very hands-on approach to where I have to palpate all of these areas very carefully to understand what goes on. And the way that I do it is after taking a history from a patient and examining them, I kind of make a 3D model in my mind of their joints and what's wrong with them and how to go about treating them. So there are many different things that cause arthritis, and we have to be really aware of them, because even Lyme disease causes a type of arthritis, but most things are degenerative and due to wear and tear. And there are some other hereditary issues which are quite interesting, and our heredity may change how our inflammation versus anti-inflammation versus regeneration happens in our own body. And this is why sometimes you see families that have people that have their joints that wear out much sooner than you'd expect, because there's other factors rather than just wear and tear. But we really need to examine all the factors. So as I said, arthritis is a little bit more than just wear and tear. And you can see on the left, we see a very healthy knee. And then on the right, we see a knee that's kind of, rotted and pitted and the bones disintegrating. And what would be more optimal than trying to regenerate the knee and try to heal the damaged structures? And we really need to look at all the damaged structures and come up with a strategy that repairs them as best as possible without an invasive surgery and replacing the joint. And in many of our patients, this is quite possible. So I think the slide, I gave it a really nice title, which is PRP is the Pac-Man of arthritis. And what does this mean? So not only do we have to repair, but we also have to remove debris. And if you can imagine, arthritis is like debris. So we use agents like PRP to go into the area and start letting these little Pac-Men in our body called macrophages come into the area and start chewing away the damage, because we want to remove some of the damage in order to lay new tissue that's healthy in a healthy area, not in a damaged area. And this is one of the ways that PRP works. So how do we do this? We basically take blood, we put it in our centrifuges under sterile conditions, and then we're able to extract out what we want. And then we are able to put it in a syringe. And then, as I say, I need to be very specific where I target the PRP treatment or the stem cell treatment to in order to get the best results. So results to me are very important, and trying to help science is very important as well. And I'm proud to be part of the team that authored the first study in regenerative medicine that could show that a torn meniscus could heal. And what we did is we had a patient who was 57 years old, and he wanted to be very active. He used to love to ski and wanted to ski with his family. He had 3 sons, and he couldn't get on the slopes anymore, and his knee would hurt all the time and it would swell. And he had tears in his meniscus. And what we did in this study is the patient was scoped and we documented the tear. And then we treated the patient over the next few months with stem cells and PRP. And then we rescoped the patient. And we'll see in the next slides what happened. So if you look on the slide on the right, you can see where the probe was that showed the tear in the meniscus. And this was removed. We only did this for visualization to look at the patient's knee. And we went in 9 months later and looked at the knee again after the treatment was done. And guess what? The meniscus had completely healed. There's no longer a tear in the meniscus. And more importantly, the patient was able to resume his activities. He was back to skiing with his sons and he was extremely happy. His knee didn't swell anymore, nor did it hurt. So this to me is really what we want. This is my ideal in regards to regenerative medicine. Not only fix what we see, but also help the patient resume what they love to do. So there are a lot of studies that back up, again, what we do for treatment of arthritis. And these are just some studies that talk about using adipose and how studies show that what we showed can be very helpful, and that administering stem cells into the knee is generally very safe and very effective and produces good long-term results for patients. Now, I talked a little bit about gel shots, and unfortunately, gel shots are not that effective. And again, they're not that effective because it's only one part of the problem is the gel. And when we compared PRP to the gel shots, PRP compared very favorably, that the results were far greater in regards to giving improvement, and the improvement lasted much longer. To me, this is a great improvement from something that maybe helps 20% of the time with a gel shot to something that can help 90% of the time. So again, research proves what we do. This really is something that should not be considered experimental. This should be state-of-the-art care. And this is what I believe that most patients should be getting as long as they're a good candidate for this. So we're going to talk about one of my favorite subjects, back pain. And while I see a lot of patients that have a lot of problems, I deal with back pain all the time. It's almost every day, day in and day out, that many, many patients are coming in for spinal issues. And part of the reason is because the things that they've been through, unfortunately, haven't been that helpful, whether it's been epidurals or nerve blocks or even surgeries such as fusions and laminectomies. And we really have to try to treat what's wrong with them. And back pain is extremely common to where most people will get back pain in their life. And we really need to try to figure out what's wrong with their back in order to help solve the problem. And that's why I put here the Greenberg method as the last thing that you see here on the slide, because the Greenberg method really is the method that I've developed, not only just to look at an MRI or look at an X-ray, but to examine the entire spine and sacrum and pelvis and hips and pelvic tilt and look at the arch of the foot and how it all coordinates together and come up with a comprehensive plan on how to solve that patient's back pain. So again, I talked about this before, and one of the most important things that I can look at is a tilted pelvis. And I can say that in my 22, 23-year career of taking care of patients with back pain with regenerative medicine, that almost 100% of patients have had a tilt in their pelvis. Now, unfortunately, like I had someone in yesterday, and he said to me, he's like, how come no one's diagnosed this? He's like, I've seen 7 doctors before, and no one's told me that I've had this, even though I walk, when I walk, I waddle. And how come no one's told me this? And I said, unfortunately, it's often overlooked and people don't know how to solve it. And this is something where I've developed a method in order to treat, and I think it makes very good and very immediate results for our patients and helps them feel better and walk better, often very quickly. And again, it's part of the solution in treating a person with their back. Be that as it may, and I'm not saying this disparagingly, but the way that I look at this is very different than the way a chiropractor looks at this in regards to how the pelvis is tilted. And I have many chiropractors as patients. I have chiropractors that send me patients, but the way that they look at a pelvic tilt is very different the way that I look at it. And I think this is extremely helpful in helping our patients walk better and feel better. And we're going to demonstrate a video of this as well. So we can go to the next. So here you're going to see a woman, the way that she walks, and she has arthritis of her hips. And you're going to see before and after the pelvic tilt what happens here. So we'll watch the video. Having a lot of back pain, hip pain, and knee pain. And when I put my hands on her pelvis, you can see that this side is really low and this side is really high. And I can't push her this way very easily, but I can easily just tap her and knock her right over like that. You see how easily she falls over? If you watch her walk, you'll see how difficult it is for her to walk. So she has this very slow, very waddling gait. Yeah, she's limping. So we're going to treat this dysfunctional neuromuscular pathway which causes the pelvic tilt. We're going to correct it and see what happens. So we performed the treatment and corrected the abnormal pelvic tilt through injection. And now you can see when I put my hands on her pelvis, they're perfectly level, as they should be. And when I push her over, she really doesn't go, where before I just could knock her over more easily. That's just we recentered her balance. Now let's watch her walk and we'll see the difference from correcting the pelvis. So again, this is just in a matter of minutes that she has a dramatic increase in her walking speed, and also she's not waddling any longer. See, the gait is much better, and the patient says that she's feeling better already in regards to the pain that she had. So these types of treatments are not only about treating the joint, but also fixing what's wrong with biomechanics, and that's what the pelvic tilt treatment is all about. So again, that's why we want to reinforce. We look at biomechanics, how the body moves, and we really want to change how the body moves and make it normal again. Because if we just fix a joint and we ignore biomechanics, then we're not going to obtain optimal results for our patients. You can go to the next, please. So a lot of people think that their problems are due to herniated discs or sciatica. And sometimes they are, but sometimes they're not. And excuse me for a second. So if we look at the slide on the left, there's something that says piriformis muscle and tendon. If there's damage in that tendon, which could happen from a pelvic tilt, then it puts a lot of pressure on the sciatic nerve and it causes a sciatic sensation. But if you would just give the person an epidural and treat the sciatic nerve, they're not going to get better. If you retilt the patient back to their normal stance and fix the piriformis muscle and tendon, well, guess what? Pressure over the sciatic nerve goes away and gets healed, and then sciatica goes away, but you haven't done anything to harm the nerve or to just numb the nerve temporarily. You've actually fixed the problem, and that's what we're all about, is fixing the problem. And if we look at the slide on the right, if you look at the lower back, this is showing all the different muscles and fascial layers and tendon layers of what's in the lower back. And again, if we just concentrate just on a disc and forget about all these other structures, well, we're really going to have mediocre results. This is why I think it's very important that when I examine someone, that we look at all these damaged structures and see what's wrong with the patient, not just what's wrong with the MRI. So again, it's not always the disc. This is showing a lot of the ligamentous structures that hold the spine together with the sacrum, which holds together with the hip. And this is why we need to look at everything. And the way that I explain this to patients is this is like the Eiffel Tower, to where what happens at the base of the Eiffel Tower influences what happens on the tower part itself. And if there's damage in one part, and let's say the tower has damage to one of the legs, well, it's going to lean a certain way and put excess pressure on other parts of the tower, which is going to make it fall apart faster. So we really need to look at the entire structure, not just one structure. So here's a very interesting case history, and this is a patient with a herniated disc, and I'm going to show you some more slides later about this that are a little more clear, but essentially, everyone thinks that if it's a disc problem to treat the disc, and this is a person who was experiencing chronic back pain for over 6 months, fell on his motorcycle a few times, had a herniated disc, and was not getting any better. And we treated the patient. So we can go to the next slide, please. So this shows the herniated disc. And if you look, it's that black material that's bulging out there at L5 and pressing on the nerve. And what we're going to do is we're going to treat the patient, but we're not going to treat the disc. We're not going to inject into the disc because that's risky. And if there's a problem, there can be a problem like what's called discitis with injecting into the disc, which can be really painful and doesn't lead to a good outcome. So we're going to treat the way that I treat, which is restructuring the spine, the spinal joints, the sacrum, the pelvis, and the hips. And we're going to see what happens. So this is after 6 months of receiving PRP treatment, and what we see is the disc resorbing on its own. So the pressure's off the nerve, the patient's feeling better, and how did this happen? And I want you to go back to the Eiffel Tower analogy, and these discs are in a vacuum, and imagine like the Eiffel Tower is like an erector set. And imagine the joints are damaged, which would be similar to the Eiffel Tower's bolts being loosened. And if they're loosened, everything kind of crumbles. So imagine rebuilding that structure and retightening all the joints, and it looks like a normal structure again. So if you take a squash disc and then you elongate the structure back to normal, look what happens to the disc. It comes back into its normal place and takes pressure off the nerve without even touching the disc. So this is one of the examples of how we do our work and what kind of results will happen with patients. And again, I think it's much better than operating on a disc or injecting into a disc to try to help someone, which again, often does not work. So, having been doing this for such a long time and having treated myself years and years ago, I think it's really important that we understand what we're doing with regeneration. We're healing tissue. We're not just placating something or using a medicine that's going to wear off over time. We're trying to get the body to rebuild and regenerate the areas of damage. And when those areas get regenerated, the pain goes away on itself because there's no more reason for the body to start triggering pain and sending signals to the brain that something's hurt when it's healed. So studies that have been done shown that if we look at this study, 90% of patients with the chronic back pain experience significant and long-term relief, which is something that I'm trying to get from my patients to experience. And I think this is really important. This is really how we solve a problem rather than just, put a Band-Aid on it or throw medicine at it. And again, there's a lot of research on different types of problems here, and this shows how studies have validated anything from elbow to heel problems to arthritis to back problems can get better with regenerative medicine. And again, 4 years later, what type of treatment do you know that's been followed for 4 years? If you take an Advil for chronic back pain, I bet you 4 years later, you're not better. If you have an epidural, 4 years later after treatment, you're not better. But if you have PRP injections into your sacroiliac joint, well, studies show that years later, you're significantly better. And I think this is a wonderful thing to do for people. And thank God I've been, patient to it myself, and thank God I've been able to heal myself with my neck and back and elbow and shoulder and all the other areas of damage that happened to me from my accident. Again, steroid shots. Steroid shots may make people feel better, but again, if it works, it wears off after months. And not only does it wear off, but it can actually harm the tissue. Steroid shots not only can produce damage to the local tissue, they can damage cartilage. They can accelerate the arthritic problem if they're used too often. And also, when steroids travel into the body, sometimes they can cause very harmful effects. Like, unfortunately, one of my friends had an issue and was treated with steroids, and the steroid went into his hip bone and basically caused the hip bone to die off. So these things are, need to really be used only when needed. And PRP, shown in studies, is better, safer, and lasts longer. So to me, this is a far superior treatment. And again, it works with how the body heals, not against it. Cortisone works against how the body heals. And this is why doctors won't give you a shot more than every few months, because it's not safe to do it more often. I don't know if any of you are Phillies fans, but I don't know if you remember when Ryan Howard, who was our star first baseman, when he ran after hitting the ball and his Achilles ruptured. Well, the reason why his Achilles ruptured is because he was having some problems there, and he was given a steroid shot into his Achilles, which then weakened it, and then the Achilles blew out when he ran. Again, using epidurals. Well, it may help some people for a period of time, but eventually it wears off. And again, studies show that using stem cells versus epidurals, the results are better, it lasts longer, and it's safer. So I think this is what we should be doing in medicine, is helping our patients and helping them for as long as we can and providing the best results that we can. So I know we've talked a lot about stem cells, and how was this all done? And what are stem cells, and how do they work? So again, we collect stem cells from the body, and as I said before, we collect them from the fat, because the fat is the richest source of stem cells in the body. And then we're able to process the fat and get the stem cells out, and then the stem cells are put into the damaged areas. Now, the interesting thing is, when I started this years ago, we used to think that stem cells were these magical cells that would transform into whatever we wanted them to transform into. And now we know that that's not the case. And I'm very fortunate that not only do I work with patients, but I'm also been an orthopedic consultant to a major biotechnology company by the name of DSM for a long time, and I work very closely with the PhD researchers. So I get up-to-date research as soon as it comes out, and we get to have very important academic discussions about what's going on in the scientific field. And what we now know is that, yes, while some cells may transform, stem cells are really the foreman of construction. And they're really getting the body to coordinate everything that needs to be done in order to make the body work and to make the body heal. And they really have amazing power to do this, and can bring things into the area that just no other cell can do. And that's why I think that stem cells are so important, and have been able to allow us to help patients in ways that we haven't been able to help them before in traditional medicine. As I showed before in that woman who had nerve damage and severe arthritis in both her cervical spine and her lumbar spine. So again, neck pain, headaches, post-concussion syndrome, this is something that I'm all too familiar with. And as I said, I suffered with this for 10 years until I was able to solve my own problems. And thank God that I did. There's many different causes of what can happen, whether it's whiplash or poor posture or working on the computer too much or texting too much or what have you. And again, what I'm trying to do, if you look at the last little sentence here, is to produce long-term healing and being pain-free through the methods that I've employed. And the treatments that I've done on athletes, whether they're Olympic gymnasts or guys in the Philadelphia Flyers, yes, I innovated these treatments on my own spine because of my own problems. So I take it very, very personally. Now, we need to really understand the anatomy of the neck and how it relates to the brain and the brainstem, because this really helps us understand what's going on here. And I'm not going to get too technical into the MRI here, but supposedly the MRI on the left is normal, which it's relatively normal. There's some spurs and whatnot. And the one on the right says that it's a normal cervical sagittal. And really it's not, because the spine is much straighter than it should be. The spinal canal is very narrow, and that increases pressure on the brainstem. And I suspect that the person on the right had some issues and had some neck pain, and that's why they had an MRI. And they're reading this as normal, but this is anything but normal. So what happens to people when they have damage to the upper cervical spine? They can have a variety of symptoms. They could have dizziness, they could have headache like I suffered from, they could have difficulty with concentration and focus. They can't track objects like I was unable to, and have blurred vision. I've had patients that have had unexplained tinnitus, which is ringing in their ears, and when we fix their cervical spine, their tinnitus goes away. We see even patients that have anxiety and tachycardia. I have a number of patients who are very healthy, who are athletic, but have neck injuries and have rapid heart rates. And that's because the area of the upper cervical spine, again, as I mentioned before, it interfaces with the brainstem. The brainstem helps to control our heart rate. And if there's increased pressure in that area, the brainstem can't work properly. And we develop all these symptoms. We have problems regulating our heart rate. So it's really a significant one. There's a lot of interaction also between the neck and the jaw and TMJ. And I think this is really important also to look at. And many patients with TMJ just go on and suffer, and no one looks at their neck and no one looks at their jaw. And then, they're told that TMJ is a magical illness, a mystical illness, and just take antidepressants and it'll feel better. And that's really not the best thing for our patient. This isn't a depression issue. This is really a lack of understanding of the relationship between the joints. And we really need to fix the joints properly and solve these patients' issues and make them better. So this is something that's really very important to me. And this is known as cervicocranial syndrome when people have these symptoms. And it's very common, but unfortunately, it's often overlooked. And again, you have to understand how to look at an MRI. And this is why I look at my own films, not just rely on someone saying, okay, well, this is normal, because it often isn't normal. And I also tell you, an MRI can fool you as well, because if we looked at MRI after MRI after MRI, we would see more problems on the films with C4, C5, and C6, because they're more likely to get herniated. But in patients who have these problems with headache and dizziness and neck pain, we often see a lot of problems in the upper cervical spine. And again, on MRI, they may appear normal. So that's why we can't just go by MRI. It's very important for us to examine the damaged areas. So again, look at the joints, not just the disc. And again, if we treat the joints and we treat properly, again, we're going to help our patient. Again, this study showed over 90% effective for patients suffering with disc herniation. And again, we were treating into the joints, not into the disc, okay? And treating into the joints is a much safer way of treating a patient. And we can go to the next slide if you don't mind. Other uses, and these are things that basically, if I can diagnose it, I can treat it. And there's many, many different joint problems, whether it's with your rotator cuff, which I touched on earlier, which again, using regenerative medicine has a much higher rate of success, and it's much easier recovery than undergoing shoulder surgery, much easier recovery. And sometimes we see in a matter of weeks patients improving, rather than going through physical therapy for 6 to 9 months and having agony and being in a shoulder sling. It just doesn't really work that well. Why not use regenerative medicine and try to heal the tears? And the long-term outcomes are much greater. We treat a lot of people with rib pain and chronic chest pain that's gone undiagnosed. Golfers and tennis elbow are very, very common. I see a lot of golfers that have back problems and shoulder problems and elbow problems. And again, we need to look holistically at this, because I've never seen an elbow problem without a shoulder problem, but many people are unaware that their shoulder may be out of place and needs to be put back into place. And then maybe there's some tendon damage there as well. And, you can't just look at a joint in isolation. You really need to look comprehensively at a patient. I do treat a lot of patients with labral tears and hand and wrist injuries. And again, I've had people that come in, oh, I have problems with my grip. I can't grasp things. I'm dropping objects. I think it's my hand. I have arthritis in my hand. Well, okay, well, maybe you do have some arthritis in your hand, but maybe you also have an elbow problem, because that's where the tendons come that control the hand. They come from the elbow. So if we treat the hand but don't treat the elbow, well, guess what? The patient's not going to get any better. If you look at the second to last thing here, Ehlers-Danlos syndrome and hypermobility syndrome, I see many patients that have this, and I've lectured to the Ehlers-Danlos Foundation about regenerative medicine. And these people are born with a deficiency in their collagen, to where their collagen, which is the connective tissue, is not made as strong. And imagine like a loose rubber band versus a really strong rubber band. This is what the patients with Ehlers-Danlos syndrome have. They have loose rubber bands, and their joints may dislocate at times. They usually end up being diagnosed sometimes with fibromyalgia, with some type of pain throughout their body, because people don't know what's really wrong with them. And they end up getting put on all these different medications until someone finally figures out that they have Ehlers-Danlos syndrome. So again, these people are born and grow up and live with collagen that's really imperfect. And they end up with pain in a lot of different parts of their body. And, it can really be very devastating. I've had patients with Ehlers-Danlos syndrome come in wheelchairs before. And if we know how to rebuild them, then we can get their life back. Interestingly enough, one of my patients was a very famous playwright, and I can't mention her play, but it's amazing, and she's won many awards for it. And she said to me, she literally had problems from head to toe, from her shoulders popping out to her feet collapsing and her knees collapsing. And she said to me, when she's, writing her plays and things like that, all she does is dream about being able to be on stage and to be an actress as well. And after her treatment, after she was done with me, she said to me, I'm going to go, and the next time that we're on Broadway, I'm going to be in a starring role, and I'm going to jump off of a box and land on the floor. And guess what? I'm not scared to do that anymore. So again, I did mention rotator cuff problems. And again, the re-tear rate is high after surgery. Again, using regenerative medicine, we can be very comprehensive in treating the rotator cuff, and PRP is better, safer, and lasts longer. Furthermore, again, we have to be comprehensive. The rotator cuff may shown up as being torn, but guess what? There's a lot of other ligament and tendon structures in the shoulder. And if we ignore them and don't treat them, well, they're not going to get better, and then the person's not going to get better. So we really need to look at proper shoulder mechanics to treat the shoulder properly and fix everything that we can in the joint. And again, that's why we have to examine patients and actually feel where the damage is. And I believe that, I have a gift and the ability to do this, and I know where the patient's pain is, and I can feel the damage in their tendons and be able to treat them based upon that physical examination. This is something that we should be learning in medical school all the time. But again, we're so stuck in technology that all we do is we look at the x-ray, look at the MRI, barely examine the patient, walk out the room and make a conclusion. And that's not the way that I do things. I think it's really important to spend time with the patient, to hear what their story is, what makes it better, what makes it worse, really examine them from head to toe, look at all the joints and how they're interconnected, and feel every little last area in that joint in order to know what's wrong. And I talked about this before. Again, stem cell treatment for rotator cuff disease, again, very, very effective, about 90% effective for people, and significantly reduced their pain and also got their function back because you're restoring the tissue. Interestingly enough, I saw a patient of mine today who happened to be a pediatrician, and he's a lovely guy, wonderful man. And I'm working on his knee and working on his shoulder. And he had severe shoulder pain and was told that he needed surgery by a top surgeon. And he said to me today, he's like, oh, I feel better. And he just rode his bike in the cancer ride, which was 55 miles, and his knee had felt good, and as did his shoulder, to where he couldn't do this before or else he'd be in a lot of pain. He's like, but I don't know if my range of motion is going to come back. And then the funniest thing is, okay, well, I think that it is back, because I tested him and he tested himself. And then he looked at me with a funny look, because the shoulder that we treated, which was previously injured, actually had better range of motion than his untreated shoulder. So again, not only are we fixing pain, but we're also restoring the tissue, which restores the normal function of the joint and makes things work naturally as they should. So when to choose surgery in regenerative medicine? Now listen, there's some times when surgery is needed, and I've even talked about how dreadful meniscal surgery is, but guess what? If your knee is locked up, yes, you may need to have a surgery on part of your meniscus. If a tendon completely detaches from a bone and ruptures, yes, you might need to have surgery. There are times when surgery may be necessary, but 99% of the time, we most likely could prevent it using regenerative medicine, and especially if we treated a problem before it became too bad. Because many of the patients I see are end of the line. They've tried everything. If we would just do this first, then I think people would have much greater outcomes, and I think there'd be much less surgery. Now, that may go against what the people at my hospital want me to tell you, because orthopedic surgery is one of the biggest drivers of revenue in hospitals. But listen, a professional athlete, I don't work for the team. And when I'm in my office, I'm working for my patient. I'm not working for the hospital. So my goal is to get the patient better and not to help the hospital revenue. So I hope to decrease their surgeries. And I know that that's what we do, but we're doing so because we're making the person better and doing what's right for them. So here's a little story with Lori Hernandez, who she's an Olympic gold medalist. She's been on Dancing with the Stars. You might see her all over TV now. But interestingly enough, I got a call, and this was about 7 weeks before the Olympic trials, that Lori had been hurt for months on end. No one could figure out what's wrong with her. She had a lot of damage into her knee, and she couldn't bear weight on it. And how was she to even try out for the Olympics? And you'll hear what she has to say. And not only obviously did she make the Olympics, but she got a gold and a silver, which I thought was pretty good. Oh, can we go back and click on that?
Hey guys, this is Lori Hernandez from the 2016 women's gymnastics team from Rio de Janeiro, Brazil. I just wanted to talk about Dr. Greenberg and how he's been so important in my gymnastics career. I came to him when I had a strain in my VMO, which is part of my knee. And after a couple of appointments, he got me back to 100% so I could compete. So thank you.
So again, I mean, as a doctor, like, what's going to give you more pleasure in your life than hearing a story like this? Taking a broken young woman who can't compete and helping her achieve her goals and her dreams. And, this is really life-changing for people, whether it's getting them out of their chronic pain, off opioids, getting them to win, whether it's scholarships or gold medals or Stanley Cups or what have you. This is what my life is about, is helping other people get back on track and really getting their life. So a lot of patients, fortunately, become, evangelical. And I don't mean this from a religious standpoint, but, we really take people who, have a lot of these different injuries and problems. And, I give my heart and soul to my patients in order to help them get better. And they really, go out and tell everyone about regenerative medicine. And this is why I've been doing this for so long, because I have such great support from my patients. And I really thank them for supporting me. They continue to refer me, their friends and their family and everyone else who will listen. And, I think this has really helped to, keep the field thriving essentially. And thank God my practice is busier than ever. And again, it takes a team effort. And my team and my family is very far reaching, from the first patient I ever treated to the last. And I'm very fortunate also to be in communication with some of my very first patients from 22 and 23 years ago, and to watch them go from being disabled to continue to be able to live life to its fullest, is really something that brings pleasure to me. Again, it's really nice not only to have conviction in what you do, but to have support. And it's really a great honor for me to be accredited by Bryn Mawr Hospital and Mainline Health, and also a teaching professor at Jefferson at the Marcus Institute for Integrative Medicine, and they send me fellows in order for me to train in the regenerative techniques that I do. And again, it's a great honor to be part of this. Furthermore, I want to thank my patient Dee, who's on the left here. And Dee is someone who had very bad spinal problems, and she did not want to get surgery, and I take care of her. And years ago, she said to me, Scott, I'm going to donate millions of dollars in the hospital because I believe in what you do, and I'm going to help you, continue to grow and develop. And, she started a Center for Regenerative Medicine, of which I'm affiliated with. And, she's one of my, greatest supporters, and has really helped me to achieve one of the things that's important to me, which is bringing greater clinical relevance to this, to where I've had the ability to give what's called grand rounds, which is like the featured lecture to lots of different departments, whether it's through Mainline Health or Jefferson, and it's really helping to expand the knowledge in this field, which is something that's really very near and dear to me. So if anyone has any questions, we can try to answer them. I really thank you for your time. Again, this is my passion. This is my life. This essentially saved my life from my accident, which was, produced 10 years of misery, but that 10 years of misery has produced 22 years of helping patients, which to me has been a complete blessing. And, I will do my best to help everyone that I can. And I really thank you for your time. So I saw a question here. Tell me about the treatment of arthritis in the hip. And, obviously we need to look at the x-rays, look at the severity of the arthritis, look at the range of motion. I saw a patient of mine today who had arthritis in the hip, and it was very important to look at the pelvic tilt and to see if the pelvic tilt was putting abnormal pressure across the hip. We try to fix the ligamentous structures that hold the hip in place. And then we'll also use stem cells into the hip joint to try to help to regenerate the damage in the cartilage. So that's part of the treatment that we do for the hip. And again, we need to look at the lower back, we need to look at the knee, and we need to look at the ankle and make sure that the person is actually walking properly. There was another question about, do we take insurance? And unfortunately, we do not participate with insurance. I know that that's a big problem, and people have to look at this as an investment in their health. Quite frankly, even though there's out-of-pocket costs to this, the costs of chronic pain are far greater, both from an emotional standpoint and an economic standpoint. And if you compared the cost of surgery to what we do, even if we look at the surgical copays, I remember one of my patients did this. She had 2 arthritic knees, and she did a comparison of what her copays would be and what her out-of-pocket expenses would be between her her physical therapy and hospital copays and medicines and everything else versus what we did. The costs were actually very similar, but guess what? She didn't have surgery. She did not have surgical recovery. She did not miss work. And her pain levels, during the procedure were far less than anything that could be experienced after knee replacement. So it really compared quite favorably, even though she had to spend the money out of her pocket. And if we take patients, let's say with chronic back pain, it's never going away, in many cases. And what's the cost of that? So I think that's what really we need to look at is cost versus benefit. And again, if I can solve their problems, and yes, it does cost out of pocket money, but you're getting your quality of life back. And with the quality of life actually comes longevity. It comes with enjoyment of life. It comes with not taking medication. It comes with not having to do physical therapy. And it comes with not having to have epidurals every 3 months. So we really need to look at this again from a holistic standpoint, not just what does it cost out of pocket, but what's it going to deliver to me, both in out of pocket costs and also in my cost of life. So, there's people that feel different ways on this. I feel like instead of, buying something for myself, whatever it was, I would rather spend money on myself to make myself better and to fix myself. And, even that's why, like with my own personal philosophies, that's why I continue to work out and to train and to keep myself in tip-top shelf. And I personally spend money on eating better quality food and taking supplements and things like that, because I want to keep my body as healthy as possible. And that's the purpose of what we do here. So I think it's really important. Someone has a question about what's the downtime for a PRP injection or a stem cell treatment. And generally the downtime is very low, especially for PRP. A patient might be sore for a day or two, typically, after something like PRP. But, again, we're not putting patients in braces. I'm not asking them to lay around in bed. I'm generally not putting them on crutches. Stem cell procedures are generally very well tolerated. And stem cell of the spine patients, it's very similar to PRP. Some other areas, though, might be a little more sore. For example, having stem cells in your shoulder or in your knee or in your ankle, yes, you might be sore and swollen and have some difficulty getting around for a week or so. This is typical. And, it could be uncomfortable for that period of time. So that would be a more typical response to some of those joints. And yes, it might be a little bit more difficult to recover from that. But again, it's a week where, it's not months and months and months of recovery. Any other questions? For hip treatment, will I be able to drive myself home? So it really depends on the hip. If someone had their left hip done, then yes, it would be very easy to drive home. My patient today, unfortunately, she has 2 arthritic hips. And will she be able to drive home? She probably could drive home, but for safety's sake, we do ask that she have someone drive herself home. And in resuming normal activity, it really depends upon what the person wants to do. So normal activity can really be resumed immediately. And the reason why is we want patients to walk around, we want patients to do things in order to help circulation. But there may be things we may not want patients to do, such as lift heavy, or, for example, if someone has a stem cell procedure, we ask them not to go in a bath or a hot tub for about 5 days or so. And we don't want them to lift heavy things like over 25 pounds. But we want people to have normal activity and build a normal life. For our athletes, we may slow down their activity initially, but then as they improve, we want to increase their level of activity to make sure that they're regenerating to the ability of what their sport demands upon them. So again, what we do is really very specific for each patient. And that's why I make individual recommendations for people, not general recommendations. So it's really very important. And for example, for some people that have shoulder or neck problems, we may start them on some type of home exercise almost immediately because there's certain muscles that might be out of balance that I need them to start strengthening for their body to function normally. So again, my approach is really based upon each patient and each patient's problem. And, this is again why, why we look at everything that we can to best determine the treatment course for each person. So again, I want to thank you for your time. Again, it takes a great team. We have a terrific team. And we are located in Bryn Mawr, Pennsylvania. If anyone has any questions or issues at any time, we're always available. You know, as I said, you know, our team is extremely dedicated, and you know, you can email us or text us. Well, actually, you can't text us. You can email us or call our office, and you know, we're always happy to see you and hear from you at any time, whether it's, you know, planning a treatment, or for people that have to come from long distances from either, you know, out of town or different states or different countries, or any type of issue or problem along the way. We're always here for you, and I always will be. Thank you so much.